Assalamualaikum warahmatullahi wabarakatuh and a very good morning to everyone. First of all, thank you for being with us in today's CPC. So I'm Dr. Aniza from Chemical Pathology Department. So it's a pleasure for us to have this opportunity to present in the CPC. So before we get started, allow me to introduce the speakers. So we have 3 speakers for today's CPC. The main speaker will be Dr. Wan Muhammad Saiful Hisam, Wan Zain. He's a lecturer in the chemical pathology department, and we are glad to have with us Dr. Andy Rahman from emergency department as a co-speaker. And we also have our Master of Pathology students, Dr. Nur Syuhadah Musa, who will present the cases. So the title of our CPC is From My Heart. So what is it all about? So we'll hear from the speakers. So without further ado, let us welcome Dr. Nur Syuhadah Musa to start with the case presentation.
Thank you to the chairperson, Dr. Aniza. Assalamualaikum and very good morning to everyone. So our CPC topic today is From My Heart. There are 5 cases that I am going to present today. So we start off with the first case. Mrs. T, 66 years old woman with underlying diabetic hypertension, ischemic heart disease and CCF, presented to emergency department with shortness of breath for 3 days and associated with bilateral lower limb swelling. Her symptom also associated with orthopnea and PND, and she did not compliance to restriction of fluid. She denied chest pain and no other associated symptoms. On examination, patient was alert and conscious, mild tachypnea with respiratory rate of 24 breath per minute. Patient was afebrile with blood pressure of 150/90, pulse rate 89 beats per minute and SpO2 95% under room air. CVS examination, dual reading normal. Lungs examination revealed bibasal crepitation and decreased air entry bilaterally. Abdomen was soft and not distended, and she had bilateral pedal edema up to the mid-shin. ECG showed sinus rhythm with ST depression on the lead 2, 3 and AVF. Serial ECG showed no evolving changes. Chest X-ray showed cardiomegaly with prominent interstitial marking and small bilateral pleural effusion. Echo was done and noted ejection fraction of 53% and grade 2 diastolic dysfunction. So on the lab investigation, as we can see, the FBC showed normochromic normocytic anemia. And other investigations such as renal function test, coagulation profile, fasting blood glucose and LFT were all within reference range. And high sensitivity troponin was requested in view of ECG changes, and noted patient had elevated trop-T of 55 nanogram per liter. And the second trop-T was sent, also elevated 57 nanogram per liter. The final diagnosis for this patient was decompensated CCF secondary to non-compliance to restriction of fluid, and patient was discharged well after 5 days of admission and treated with furosemide. For the case 2, Mr. Z, 50 years old gentleman, underlying diabetic hypertension and end-stage renal failure with IHD, had presented with central chest pain for the past 1 week and worsening post hemodialysis at 3 hours prior to presentation to the ED. He described the pain as heaviness in nature and radiating to the back with pain score of 7. His symptom associated with shortness of breath and lethargy. Otherwise, he denied other associated symptoms. And on examination, he was alert, conscious, and not tachypnic. All the vital signs were stable. Cardiovascular examination, dual reading normal. Lung examination revealed bibasal fine crepitation with equal air entry and no pedal edema. ECG showed ST depression at V3 to V6, de-inversion of lead 2 and AVL, and frequent PVC. Serial ECG was done and no evolving changes. Chest 3 showed cardiomegaly and echo showed ejection fraction of 33% with grade 3 diastolic dysfunction and global hypokinesia. So from the lab investigation, from the FVC result, we can see patient had normochromic normocytic anemia. The renal function test showed elevated urea and creatinine, consistent with patient underlying illness, underlying CKD, and end-stage renal failure with ejection fraction of 14. Other investigation, LFT and coagulation profile were within reference range. And troponin T was sent, noted elevated 140 nanogram per liter. And the second trop T was sent, also elevated 220 nanogram per liter. So the final diagnosis for this patient was non-STEMI with underlying IHD and poor left ventricular dysfunction. Patient had completed IVI heparin for 48 hours and discharged well after 3 days of admission without further chest pain. For the case 3, 65-year-old man who is smoker, underlying ischemic heart disease, had presented with left-sided chest pain for 2 days. The pain radiating to the left arm and associated with diaphoresis with pain score of 7. Otherwise, no palpitation and no shortness of breath. On examination, patient was alert, conscious, not tachypneic. Vital signs were all stable. Cardiovascular examination, dual rhythm, no murmur. Lung examination, equal entry and no pedal edema. ECG on arrival showed T-inversion at lead V2 until V5. Chest X-ray showed no cardiomegaly and echo showed ejection fraction of 60% and no regional wall motion abnormalities. From the lab investigation, the FVC, RFT, LFT, and coagulation profile were all within reference range. The troponin T was elevated 58 nanogram per liter. And patient was diagnosed as a non-ST elevation MI. However, patient developed another episode of severe chest pain after 6 hours, which is not relieved by sublingual GTN. Repeated ECGs done noted evolving changes showing new ST segment elevation in lead V2 up to V5 and reciprocal ST depression in the lead 2, 3, and AVI. The repeated troponin T was sent an elevated 81 nanogram per liter. And the revised diagnosis for this patient was reinfarction of the MI. For the case 4, Mr. M, 50-year-old Malay male, who is active smoker with no previous Mr. M, 50-year-old Malay man, active smoker with no previous medical illness, presented with central chest pain started 2 hours prior to emergency department. He described the pain as crushing in nature, radiated to the left arm and to the back, and lasted about 30 minutes with pain score of 8. His symptoms were associated with nausea and mild shortness of breath. Otherwise, no other associated symptoms. On examination, he was alert and conscious. Vital signs were all stable. Cardiovascular examination, dual rhythm, no murmur. Lung examination revealed fine basal crepitation and no pedal edema. ECG showed sinus rhythm with ST depression on lead 1, 2, V5, and V6. Chest X-ray showed cardiomegaly with mid-upper lobe diversion. From the blood investigation, the FBC, RFT, LFT, coagulation profile, and fasting blood glucose were all within the reference range. And the troponin T also is not elevated, 5 nanogram per liter. Patient was diagnosed to have unstable angina and subsequently admitted to the medical ward for the further treatment. And however, in the ward, symptom patient was worsening and repeated ECG in the ward showed new changes, RBBB pattern, and ST depression on lead 2, 3, AVF, V5, and V6. And the repeated troponin T was sent, also noted elevated 25 nanogram per liter. And the revived diagnosis for this patient was non-STEMI. And he discharged 5 days later with stable vital sign, no further chest pain after completing the anticoagulant treatment. And the last case for today, baby A, 10 months old Malay girl. She was previously well, and this is the first hospitalization. The child has been unwell and less active for the past 1 month with productive cough for 3 days. And the mother brought the child to emergency department as she noticed the child had bluish discoloration at all peripheries. Mother denied any ill contact. And for the family history, child is the youngest from the 3 siblings. Elder brother and sister were both healthy and no significant cardiac disease in the family. On examination, patient was pink but lethargic looking, cold peripheries, CRT less than 2 seconds, respiratory rate of 32 and no obvious chest recession. BP 92/58, pulse rate 92, SpO2 95 to 96% under room air. Cardiovascular examination, dual rhythm normal, apex beat not displaced, lungs equal breath sound, abdomen was soft and not distended, but patient had pedal edema up to the mid-shin. Bedside echo was done and noted patient had dilated chambers, poor left ventricular contractility with ejection fraction of 34%. ECG showed RBBB changes, chest X-ray showed cardiomegaly, haziness bilateral lung fill. On the blood investigation, patient had thrombocytopenia, most likely second to underlying sepsis, and deranged coagulation profile with elevated D-dimer. Renal function tests were within reference range. The liver function test showed mild transaminitis with mild elevation of AST and ALT. Respiratory viruses were all not detected. And serology also sent noted EBV IgM was positive, indicating recent infection of the EBV virus. Blood CNS and the CRP also sent, and blood CNS showed no growth. CRP for day 1 and day 3 both were negative. And troponin T for this patient also elevated 27 nanogram per liter. The final diagnosis for this patient, viral myocarditis with poor left ventricular function and transaminitis, and cover for secondary bacterial infection. She had completed IV immunoglobulin, IV Mironol, and IV cefuroxime, and discharged well with no cardiac failure symptom after 1 week admission. So before I end my presentation, I would like to summarize all the 5 cases that I have presented just now. So for the case 1, we had patient of 66-year-old diagnosed as decompensated CCF secondary to non-compliance to restriction of fluid. So the initial trop T for this patient at 55 nanogram per liter, and this repeated trop T was 57 nanogram per liter. For the second case, 50-year-old diagnosed to have non-STEMI with underlying IHD and poor left ventricular dysfunction. Patient had underlying end-stage renal failure. So the initial troponin T was 140, and the second troponin T was 220 nanogram per liter. And for the third case, we had a case of 65-year-old with infarction. The high sensitivity troponin T was 58, the initial one, and the repeated one was 81 nanogram per liter. For the fourth case, a 50-year-old diagnosed initially to have unstable angina and progressed to the non-STEMI with initial troponin T of 5, and the second troponin T was 25 nanogram per liter. And the last case, we have a baby 10-month-old diagnosed to have a viral myocarditis with poor left ventricular function and transaminitis with a troponin T value of 27 nanogram per liter, which was elevated. That's all for me. And next, I would like to invite the next speaker, Dr. Wan Saiful Hisam, our chemical pathologist, to continue with the presentation.
Thank you, Dr. Norshuhada, for the 5 case presentations. Okay, so Again, thank you to Chairperson Dr. Aniza. Assalamualaikum and good morning to all professors, fellow lecturers, students and the rest of the audience. Okay, so I will continue with our CPC today entitled From My Heart. So I guess some of the audience can already guess what our CPC is all about. Okay, so basically we are going to discuss regarding biomarker cardiac troponin, specifically troponin T, which is offered by our lab. Okay, so starting off, I will start with the definition of myocardial infarction, or we call it SMI. So this is our latest CPG guideline 2021 by Ministry of Health on the management of non-ST elevation MI. So based on the fourth definition of MI, which is included in our CPC, MI is defined as a significant when there is a significant rise and or fall in cardiac troponin with at least one of the value above the 99 percentile upper reference limit or more than cutoff, with at least one of the followings, which is the clinical history consistent with the ischemic pain, ischemic origin, and then the ECG changes of ischemia or infarctions or development of pathological Q waves, and also imaging which shows the loss of myocardium or new regional wall motion abnormality, and also identification of thrombus by angiography or autopsy. So there are no clear guidelines regarding to significant rise and or fall. However, based on the consensus, it is decided that changes in cardiac troponin concentrations of 20% or more is considered as significant changes. Okay, so next, let us recall regarding the ACS or acute coronary syndrome. So ACS can be divided into ST elevation or non-ST elevation. Okay, so non-ST elevation MI without the elevation of cardiac biomarker, we call it unstable angina. And non-ST elevation with the elevation of cardiac biomarker, we call it non-ST elevation MI or non-STEMI as short. For ST elevation with elevated cardiac biomarker, we call it STEMI or ST elevation myocardial infarction. So next term is what is myocardial injury? Okay, so myocardial injury basically is defined as the elevation of cardiac troponin above the 99 percentile or cutoff. So in our lab, we're using the high sensitivity cardiac troponin. So the cutoff is 14 gram per liter. So if the troponin value above 14 gram per liter is indicate myocardial injury. So myocardial injury can be divided further into ischemia or non-ischemia. So ischemia is our MI or myocardial infarction, meaning that the presence of ischemic evidence of ischemia, whether as I mentioned before from clinical or ECG, also thrombus identification by the angiography and also autopsy. And for non-ischemia causes of myocardial injury, the causes include, for example, myocarditis. Okay, so why we need to differentiate or we need to know regarding the definition of myocardial injury? Because cardiac troponin itself is a sensitive marker of myocardial injury and not for myocardial infarction. Okay. Okay, so this diagram is showing the spectrum of myocardial injury and also myocardial infarction. So as you can see, myocardial infarction is a subset of myocardial injury in the presence of evidence of ischemia. And these various clinical entities, for example, listed there, hypoxemia, anemia, is involved in the pathological, in these two pathological conditions. So in short, the point that we want to stress here is that myocardial injury is not the same as myocardial infarction. Whereas, myocardial infarction is a subset of myocardial injury that need to be supported with the evidence of ischemia. Okay, now the roles of troponin apart from diagnosis is also in the risk stratification or prognosis of the patient. So this will be further explained by Dr. Ande. Okay, so now let us take a look regarding the timeline or history of cardiac biomarkers in myocardial infarction. So starting off during the 60s, okay, MI is diagnosed based on chest pain, ECG, and the earliest cardiac biomarker is AST. So jump forward to the era of 70s to 80s, whereas this is the era of CK and CKMB. And then the troponin, the first conventional troponin set in during 1990s. And during the year of 2010 started with the high sensitivity troponin measurement. Okay, so cardiac troponin has been used for diagnosis of MI for around more than 30 years, and for high sensitive troponin is already more than 20 years. Okay, so it's not really new biomarkers. Okay, so based on our CPG, it is stated that both cardiac troponin T and I are the most sensitive and specific biomarkers for myocardial injury and necrosis. So in the presence of when there is a availability of the testing for that cardiac troponin, so other cardiac biomarkers, including CK, CKMB, are not useful for the diagnosis of acute MI. Okay, so now let us look back at the structure of the troponin. So what is troponin? Okay, so basically troponin is a contractile apparatus in the muscle. Okay, so it has 3 subunits. Okay, the first one is troponin T, which attaches the troponin complex to the actin and tropomyosin. Second is troponin I, which inhibit the interaction with myosin heads in the absence of sufficient calcium ion. And troponin C, which serve as the calcium binding site. So this troponin protein, together with the presence of calcium, it facilitates the interaction between actin and myosin as part of the sliding filament mechanism for contraction, for muscle contraction. So troponin T and troponin I has the shows high sensitivity and specificity towards the cardiac myocytes. So any detectable level of any detection of troponin T and I in the blood shows presence of cardiac injury, cardiac injury. Whereas for troponin C, it shares the same amino acid homology with the skeletal muscle. Thus, it is not used as a cardiac biomarker. Okay, now let us take a look at troponin kinetics. Okay, so the troponin started to appear in the serum around 3 or 4 hours until 10 hours after the onset of MI. Then it peaks around 12 to 48 hours. Then it started to reduce but remain elevated for around 14 days. Okay, so as you can see, compare with the chronic myocardial injury, the acute myocardial injury shows elevation and reduction. And whereas in the chronic myocardial injury, the level, the elevated level is stable above the cutoff. Okay, now what is the, let us take a look at the difference between conventional versus high sensitivity cardiac troponin assay. Okay, for cardiac troponin, for conventional assay, it unable to detect the lower troponin concentration. So any detectable troponin in the conventional assay considered as abnormal. Whereas for high sensitivity assay, it can detect up to 100-fold lower troponin concentration. Okay. Then for the conventional assay, it unable to reliably rule out MI for 12 hours or more after the symptoms. Whereas for high sensitivity cardiac troponin assay, the diagnosis of MI can be made within 3 hours after the symptoms. So this is truly an advantage because diagnosis of MI can be made earlier and thus intervention. Okay. Okay, so in chemical pathology lab, so our aim is to provide accurate and precise laboratory results within our laboratory turnaround time. So for cardiac troponin request is considered as urgent request. So the laboratory turnaround time is around 1 hour from receiving sample until the results. We also provide a consultation for interpretation of the test result. Okay, so the following is the SOP of our lab in the request for the high sensitivity troponin T test. Okay, first is all requests for high sensitivity troponin T must go through our medical officer or consultant on call consultation. Then, as I mentioned, the TAT is around 1 hour from sample received to results. And request for third high-sensitive troponin T in 40 days must go through clinical specialist consultation. Okay, now looking at this one article, okay, entitled a third troponin T blood sample is not cost-effective in patient with suspected non-ST segment elevation ACS. Okay, so in this study, they look around patient 534 patients with suspected of having ACS. Then and from this 534, around 124 had elevated cardiac troponin level, and from this 124, only 4 patients or 3.2% of the patient had troponin value increase in the third sample. Okay, so it is low. So based on this study also say that the third troponin may lead to the prolonged hospital stay, and the routine testing of third troponin may lead to prolonged hospital stay and also increase cost. So that's why this study is in line with our SOP, which is the third troponin T, if it is indicated, must go through the consultation by the clinical specialist. Okay, another study here is titled Troponin Thing Before You Request. Okay, so this study was done at one of the busiest hospital in the district in the UK. So they randomly assessed the nature of the troponin request, okay, for 1 week, and they found out that most of the requests were made without clinical justification, because the requests were made at the triage, okay, not before the assessment by the clinician. So this study concluded that the troponin request without proper clinical justification may lead to inappropriate workout, increased hospital stay, and also cost in terms of tests. Okay. Okay, so looking back a little bit, looking a little bit regarding the statistics. So this is the high sensitivity troponin test request in our lab from the year 2020 until last year 2022. So as you can see, the request is increasing from years by years with the increment around 30 to 36%. And the most request is around 70% came from emergency department. Okay, again showing the statistic, which just shows that the most of the request is from emergency department. And as you can see, there is a slight reduction in the request from the emergency department from the year 2020 to 2021, from around 76% to 55%, and this is mainly due to COVID-19 pandemic and also lockdown. Okay, moving on with the interpretation of cardiac troponin. Okay, first, when we have the elevated cardiac troponin above the cutoff, okay, next we need to decide whether it's an acute or chronic. So in the acute, it has the troponin levels, we have a rise and or fall with the 20% significant percentage. Okay, then in the acute, with the presence of evidence of ischemia, then we call it acute myocardial infarction, which the causes can be ACS or non-ACS. If the acute myocardial injury without evidence of acute ischemia, then we just call it acute myocardial injury. Okay, and the causes can be divided into cardiac, non-cardiac. Cardiac, for example, heart failure, myocarditis, and for non-cardiac, it can be due to sepsis or renal failure. For chronic myocardial injury, the causes include chronic structural heart disease, ischemic heart disease, and also from CKD. And analytical errors causing elevation of troponin T is rare. Okay. Okay, so this diagram showing the levels of the cardiac troponin with causes and also associated with PPV and NPV. So as you can see, the higher the troponin levels, the higher the positive predictive value for diagnosis of MI, whereas the lower the troponin level below the cutoff, the higher the negative predictive value for MI. So positive predictive value means that the amount of the percentage of patients that truly have the positive result with the presence of disease. In this case is MI. And then for negative predictive value, it is means that the percentage of the patient that truly have the negative lab result with the absence of the disease. Okay, so far we have heard that troponin is the preferred cardiac biomarkers, okay, as it's more specific and sensitive. But as with all other test results, what are the challenges or pitfall of using the high sensitivity troponin for diagnosis of MI? So we go to the first false positives and false negative. Okay, false positive meaning that the result is positive above the cutoff, but in the absence of disease clinically. Whereas the false negative meaning that the test result is negative, but with presence of the disease clinically. So for false positive, okay, listed there is for the causes include 13% of patients with chest pain and raised high sensitivity troponin proved not to have MI, and this may not reflect myocardial injuries. This may reflect myocardial injuries and not MI. And also the elevated troponin had been shown in the marathon runners, which had increased troponin level, and in one study stated that the level can be up to 40 nanogram per liter, and this mainly due to increased cardiac stress. Analytical interference also can cause false positive. For example, the presence of macrotroponin, which is the formation of complex between troponin and also immunoglobulin, and usually patient is asymptomatic. Okay, for false negative, okay, is include the patient with earlier presentation of less than 3 hours. As I mentioned before, our high sensitivity troponin assay can detect elevation from 3 hours of symptom, but if patient presented earlier, then the result might be the troponin level might not elevated yet. Okay, analytical interference also can cause false negative results. Okay, this for example biotin or some for example biotin. So if clinicians suspect of a patient having analytical interference, okay, you can contact lab for further workup. Okay. Okay, so let's go back to the case summary. Okay, this is the case summary presented by previously by Dr. Nashuhada. Okay, so for the case 1, this patient presented with decompensated cardiac failure secondary to non-compliance to fluid restriction, and as you can see, the high sensitivity troponin T is elevated. Is above the cutoff 55, then elevated to 57. Okay, so however the elevation is less than 20%. So looking back at the algorithm, okay, so the elevation as stated there from 55 to 57, so less than 20% change. So in this patient, it is presence of chronic myocardial injury. For the case 2, this is a patient diagnosed with non-ST elevation MI with underlying end-stage renal failure, and the cardiac troponin for the baseline is elevated 140, and repeated is further elevation of 220, and this is as you can see is more than 20%, right? Okay, so a little bit regarding elevation or why cardiac troponin level is increased in the CKD. Okay, so the mechanism of increased troponin level in renal impairment or end-stage renal failure include first is increased ventricular pressure. This is secondary to overload, which leading to stretching of the myocardium and also lead to myocardial injury and release of troponin in the bloodstream. And secondly is due to reduced renal clearance. So as we know that the troponin is being cleared by the renal, and also due to direct troponin effects on the myocardium secondary to uremia. So the presence of CKD in ACS patient is a high risk additional factor for increased mortality, and the severe the CKD, the higher the mortality in ACS patient. Okay, so what to do? What to do in if the patient's CKD presented with a suspected of ACS? Okay, first, serial measurement or serial testing of troponin is more important than to rely on a single test. So when it's suspected, it's important to do serial over 3 to 6 hours. And as I mentioned, a distinct rise and fall, so we can use as 20% of cutoff over baseline with clinical suspicions and other supporting modality for ischemia can support the diagnosis of MI. However, don't forget that these changes can occur in acute volume overload and congestive heart failure. So it is important to correlate with clinical condition and other diagnostics tool, for example, ECG and echo, for the diagnosis of MI. Okay. Okay, so in our case, it is more than 20% change. Okay, so this is one of the this is a systematic review and meta-analysis recently published last year regarding the cut-off for troponin level in patient with renal impairment and end-stage suspected of MI. So the cut-off for values for troponin in patient with renal impairment with MI stated based on this study is around 48 nanogram, and for patient on dialysis, the cut-off even higher, around 239 nanogram per liter. However, this systematic review and meta-analysis did not include the level based on the CKD stages. Okay, next we're going to discuss together with for the case 3 and case 4 as it is related to the next point of discussion. Okay, for case 3, the diagnosis is reinfarction. Okay, and for the case 4, the initial diagnosis was unstable angina and later revised to non-ST elevation MI. Okay, for the case 3, the initial diagnosis, the initial troponin level was elevated 58, then repeated is a further elevation of become 81 nanogram per liter. Whereas for case 4, the initial troponin level was normal, then elevated. Okay. So regarding the term, what is reinfarction? Okay, so reinfarction actually is the acute MI that occurs within 28 of incident or recurrent MI. If more than 28 days, it's called recurrent MI. So how to diagnose reinfarction? Okay, first, okay, if a patient suspected of reinfarction, the first sample need to be taken immediately. Then again, repeated sample should be obtained within 3 to 6 hours later. And to diagnose reinfarction, it requires 20% increase in the troponin value in the second sample. And if the initial troponin concentration is normal, the new acute MI apply. So for case 3, there is a more than 20% increase. So that's why the diagnosis is reinfarction. And for the case 4, initial troponin was normal, then elevated. So new acute MI applies. Okay. And for the case 5, okay, this is a pediatric cases. Of the 10 months old baby girl. So he diagnosed with viral myocarditis with poor LV function and transaminitis. So the high sensitivity troponin level around 27. So based on this caliper reference interval, it is elevated. Okay. So actually, what about the cardiac troponin level in pediatric age group? So basically, it is quite challenging, okay, because first is the coronary artery disease is quite rare in patient. However, the troponin testing or elevated troponin may help to detect myocardial injury. Okay, as mentioned that troponin is the specific or sensitive cardiac biomarker for myocardial injury, and also, however, the limitation for the troponin testing in the pediatric age group is the lack of reference interval, okay, available for the pediatric age group. So in our essay also, there is no pediatric reference interval provided by the manufacturer. Okay. However, just to share to you that there are some of the reference interval that we can use. Okay, so this one is by Caliper, short form for Canadian Laboratory Initiative on Pediatric Reference Interval. So what is Caliper? Caliper actually is a comprehensive database of various testing around 200. Okay. 200 testing that had been used by the clinicians and also by the patient. So this caliper is so in this era of the smartphone, so luckily they have the free apps. Okay, you can download it in the App Store or Google Play Store. So you need to so we can choose the test, okay, and enter the patient's results, and with the unit and gender and patient age group. So as I already entered for this for our patient here, and what interesting is that when you click the button evaluate, it can evaluate for you. Okay, so for this For our patient, it is elevated, okay, based on this reference interval by caliper. Okay, so this is the reference interval by the caliper. Okay, next, this is a little bit close to us. Okay, this is a study shows the age specific reference value of fifth generation. Fifth generation meaning that the high sensitivity in the Chinese children. Okay, this studies recently published. Okay, so compare with the caliper. So these values, the values in this study is more or less the same, except in the newborn and up to 4 months. Okay, so basically the best reference interval basically to use is in our population that have include our population. However, unfortunately, it is not established yet. And other reference interval in other population can be used, but it needs to be verified first. Okay. Next challenges is that in the interpretation of the cardiac troponin in the critical ill patients. So in ICU or critical ill patients, the elevation of troponin is common and it associated with adverse prognosis regardless of the underlying disease state. Okay, so the mechanism can be due to type 2 of MI, which is secondary to imbalance between oxygen supply and demand. And it is challenging because there is no consensus or on the appropriate treatments and management. So basically, when the patient recovers from the illness, the clinical judgment can be used to for further evaluation for any suspected of coronary artery disease or any structural heart disease in the patient. So clinical judgment is important for further evaluation of elevation of cardiac troponin in a critical ill patient. Okay, so before I end my talk, just to share our e-poster presentation. Okay, this is so this e-poster presentation had been presented during the last National Pathological Conference in 2021. So our department, in collaboration with emergency departments and medical department, have presented a poster entitled "A Practical Improvement for Cost Effectiveness Troponin Test After Discontinuation of CKMB in Tertiary Hospital in our hospital." Okay, so in May 2020, we decided to discontinue the CKMB testing. To be started with high sensitivity troponin T in line with the recommended by the guidelines. So this had led to the sudden increase in the troponin testing and lead to substantial cost burden to our laboratory. So we had made certain practical improvement, which include regular discussion among physician and laboratory consultants, and also providing standard operating procedure SOP without compromising patient care, and also improvement in LIS, our laboratory information system, for the unnecessary troponin T requests. Okay, so consequence from this practical improvement, we had able to reduce the financial burdens of up to 8,500 per month. Okay, and this our poster has been awarded with for the second place during the conference. Okay. So with that, I thank everyone for listening to my talk, and I welcome any questions, comments, and suggestion. Okay, now I would like to invite Dr. Andi Rahman from Emergency Department to continue with our CPC.
Assalamualaikum and good morning. Thank you, Dr. Saiful, for very informative talks regarding troponin T. I'm sure everybody now already know in detail about the troponin T, the good, the bad, and the ugly side of it. So, and I'm pretty sure so many of you may be puzzled why ED is the highest user of the troponin T test, kan? After all, why not the medical department and why not the CCU? After all, it is from the heart, kan? From the broken heart. So why ED is the highest user? So now it's my job to share with you how we use troponin T in the emergency department. Okay, before the arrival of troponin T in hospital USM, I know it is very late already pun, because high sensitivity troponin already in the market since 2010 as mentioned by Dr. Saiful, but we start at 2000 apa tadi? 2020, 10 years behind. So before the era of the troponin T, we in the emergency department, we have difficulties to differentiate patient that came to the ED with chest pain, because mainly in our population kat Kelantan ni, the description of pain ni sangat-sangat different from other tempat kan. Some describe as sekok, seeh, sooh, senok, and even some say when the pain come dia rasa ra gitu. So all the description is very very unhelpful, and without good screening tools, most of them at that time was referred to medical lah kan, because we cannot simply discharge the patient because we're not sure whether it is cardiac in origin ataupun tidak. So most of the patients were referred to medical for admission and observation. And in the end, when discharged, sometimes turn out actually to be only GERD or gastritis, which actually can be treated as outpatient. And this has caused unnecessary usage of hospital resources lah kan. And at the time, what we have is the CK-CKMB ratio, and the usage of CK-CKMB ratio slightly help in the diagnosis. However, it only elevated after 6 or 9 hours after arrival or after symptom. And when patient arrive early, it will take valuable ED resource lah, bed kan, sebab kita nak kena wait for 6 or 9 hours before we can actually test the CK. And even if after that, only if the CK value high, barulah the CKMB test will be performed and we can do the CK-CKMB ratio. However, even with this CK-CKMB index or CK-CKMB ratio, the sensitivity is very low and it's not a good tool for screening. So when the troponin T arrived at emergency department, we are very happy, kan? We are very happy because it changed the way we manage chest pain patient in emergency department. That's why you can see the sudden surge of test of troponin T kan, as presented by Dr. Saiful, because the troponin T they offer earlier detection, especially the high sensitive troponin. It can detect the presence of troponin in the blood as early as 3 hours from the onset of symptom, and it also provide better sensitivity and specificity as compared to the CK-CKMB previously. So it making it is the perfect tool to replace CK-CKMB index in the emergency department. However, the troponin T by itself, it doesn't really help much actually, because as mentioned earlier also, elevated troponin doesn't mean myocardial ischemia or myocardial infarction. It only indicate myocardial injury. And there are so many causes that has been presented previously that can cause the increment or the positivity of the troponin, and not only myocardial infarction. So to help with this, in emergency department, we use scoring tools or scoring system that help to differentiate whether the chest pain is cardiac in origin or not from cardiac in origin. That is only our interest lah. When patient come to ED with chest pain, our interest is only to differentiate whether the chest pain is from the heart or from other source. Okay, so one of the most highly used tool in emergency department is kita guna heart score lah. Heart score has been validated. It is a scoring system to differentiate or to actually to identify patient that present to ED with chest pain, and to categorize them into low risk category, medium risk, or high risk group. This is the outcome is MACE lah in 6 weeks time, and MACE in this scoring is referred to cardiac event such as death, ACS, STEMI, or needing for PCI or CABG. So when patient come to emergency department, we score the patient based on the history, the ECG changes, the age, and the risk factor, and also the troponin value. Okay. If the patient is categorized under the low risk group, which that is score 0 to 3, this patient may be discharged home with follow-up. If the score is 4 to 6, this is into the medium group or intermediate group. This group of patient is advised to be admitted for clinical observation. And the patient with high risk group, the high score, will be benefited from early invasive strategy. Okay. And we discharge patient usually with follow-up lah. Follow-up to the nearest clinic or our KRK. We able to discharge the patient because the risk for MACE in 6 weeks is only 2.5%. But some of us or some of the doctors also not very comfortable with 2.5% kan. Because 2.5% means roughly around 1 every 50 patient will develop MACE if the low risk group, in the low risk group. So if we have in ED we have 10 patient per day and that come with low risk chest pain, in 5 days then we can have one patient with MACE lah, to put it in simple term. So to make it more to bring down the risk lower, we use the HART pathway. HART pathway is a combination of HART score with serial troponin testing. Okay. There are some few pathway that is recommended by the ESC at 0 hour and 1 hour. 0 hour is when patient presented to emergency department, and 1 hour is 1 hour after the initial test. And we have 01, 02, and also 03 hours. 01 and 02 is the most recommended by the ESC guideline. With the 03 hours is option if the patient is really in high risk group and the troponin test after 02 is not really conclusive. In this pathway, patient will be classified according to the HART score to low risk group and also high risk group, less than 3 or 4 or more. The patient with less than 3, actually all patient will have to undergo serial troponin at this interval lah. Mostly is 01 or 02. Depend on the first test. If it's if the first test positive or not lah. If the serial test negative, then the patient is safe for early discharge. If the serial test positive, then it need to admitted for the further testing lah. Okay. Apart from the HART pathway, there is another alternative that we can use in the emergency department. We use the ADAPT protocol. However, we are less favor for this protocol because this protocol they use the troponin the TIMI score instead of the HART score, and component of the TIMI score ni is not really practical in emergency department because there are this component of non-CAD with stenosis of more than 50%, which we don't have this information in ED. This information can be traced from the folder lah, which is akan delay our management. That's why in ED we use the HART score, and a study has been done. Multiple studies have been done actually to compare the HART score and ADAPT protocol, and within the result shows that within a cohort of ED patient with acute chest pain, both ADAPT and also HART pathway shows very good sensitivity to diagnose or to classify patient with low risk group. However, HART pathway outperform ADAPT by correctly identifying more patient with low risk group and safe for discharge. So that's why in ED we use the HART pathway lah. And also there are certain group of patients that have chronic troponin raise in the blood, as been present earlier. Patients such as young patient with the CKD patient, the heart failure patient. So all these patients, even when they have no symptom, when we test the troponin, likely it will be positive. The high sensitivity troponin test will be more than the normal value. So this poses challenge for us lah to actually classify whether the symptom that the patient have is actually due to heart problem or due to the underlying disease. So for this type of patient, we use the delta troponin, the delta value of the troponin in the serial troponin is has been recommended by the European Society of Cardiology. The value that need the changes that is need to be present to consider significant is if it depend on the first troponin. If the first troponin is elevated, then it required a 20% change of the delta from the second troponin. If the first troponin is normal or it borderline elevation, then it required a delta of 50%. Barulah it considered significant. And that's how we use troponin in emergency department lah. As you can see, most of the troponin dia jadi banyak penggunaan tinggi because of we use serial troponin. We repeat after the first troponin. But the truth is, if in emergency department, if we just follow the true need of troponin in emergency department, actually is only few sample je, because in our setting, what we want to know is whether the patient can be safely discharged or need to be admitted, kan? So most of the serial troponin that is done in our department is actually for the prognostic, for the decision of the management of patient, which actually in ED kita tak interested pun for that time being, kan. It's more to the internal medicine side lah and the medical side untuk further management of the patient. However, we do that request because most of the patient will stranded in our department for few days. So kalau kita tak buat early in the ED, the management of patient will be delay lah, kan. So that's why you see in the data, the request is most of the request is from ED. The true ED request actually is very low sebenarnya, because to diagnose, let's say, as I give you example, if you want to diagnose STEMI, kan, we don't need the troponin. We can just use the clinical history and also the presence of typical ST segment elevation is enough for us to initiate the treatment for STEMI. Actually, we don't need the troponin level to treat patient with STEMI. Same with the non-STEMI or unstable angina. Because most of the patient can be need admission even without the troponin. Only the important of troponin is to decide whether the patient needed to be admitted into the CCU or it can be admitted into the general ward. So the true request for emergency sebenarnya very low lah actually. The rest is we are helping others in managing the patient. Okay, that's all. Thank you.
Thank you, Dr. Andi. Okay, so before we end and we take we look at some take-home messages, and I will entertain some of the questions in the chat box. So for the take-home messages, the high sensitivity cardiac troponin is the most sensitive and specific biomarkers for the diagnosis of acute MI and must be supported by other evidence of acute ischemia. Cardiac troponin is specific to myocardial injury, not MI. And serial measurement of high sensitivity troponin is important in diagnosis of acute myocardial infarction in patients with chronic troponin elevations. And interpretation of troponin elevation in certain types of patients, for example, critically ill and pediatric care, are challenging and should be supported by other modalities and clinical conditions. Okay. So
we have questions from Dr. Tengku Muzaffar, if he's still online.
Okay.
I already unmute Dr. Tengku. Okay. It's a false alarm, so you can actually answer the questions from the chat box. Thank
Okay.
you.
For the first question, for the first question, which is more accurate, troponin T, I, and C. Okay, so as I explained before, okay, so C definitely is not is not suitable to use for cardiac biomarkers, as it has the same amino acid homology to the skeletal muscle. Okay, so between troponin T and I, so as stated in our CPG, both can be used. Both are shows high sensitivity and specificity towards cardiac myocytes, and both can be used as cardiac biomarkers. However, the value between both tests are not interchangeable, meaning that when the patients, for example, when patient came with the result of troponin I in one center, and then they came to one center that using the troponin T, so the results cannot be interchangeable, okay, because difference of the difference of the method and measurement. Okay, and then for the second question, false positive among marathon runner means during the activity or after activity or recovery. Okay, so there is one study that they shows that there is elevation of cardiac troponin in post activity or post marathon. However, this is a benign condition and related to the transient cardiac injury, and this is not associated with the risk of atherosclerosis, thrombosis, and any thrombosis phenomenon. Okay, so it's just benign and transient transient cardiac injuries. As I mentioned, that troponin is a specific and sensitive marker for cardiac injury and not myocardial infarction. Okay, and then one question, test troponin test had commercially made test with faster result. Oh, I think maybe this related to the POCT for the point care of testing. Okay, so there is a POCT test. Okay, for example, troponin T and troponin I. Okay, but it's not available for yet in our center, and okay, but mind you that the POCT, although it is maybe faster bedside, it has own limitations. Okay, and sometimes because of it has own limitations in terms of analytical. Okay, and if it is advisable that if we want to make testing using the POCT, it should be the same testing as the analyzer in the lab. For example, it is troponin T testing. If the lab there is available of troponin T testing, then it is encouraged or advisable for POCT troponin T, not troponin I. Okay. Okay. So another question, Salam, for suspected reinfarction, can we use CKMB as biomarkers for evaluation? Yes, because previously, as you know, that CKMB usually the level is going down between day 4 and day 5. However, as I mentioned before, based on the guideline, when there is availability of the troponin testing, so based on the guideline, we have to use troponin testing, whether it's I or T, because troponin also can be used to diagnose reinfarction with the 20% increment from the baseline. Okay. Okay. Does split overload state affects troponin level? Okay. So in terms of you need to look the effect of the fluid overload, meaning that as I mentioned that the troponin is very specific to cardiac injury. So if the any states or any condition, okay, that lead to the worsening of the cardiac injury, then it will lead to the elevation of the troponin level. Okay. Okay. And heart failure. Okay. Okay. So I guess that's all the questions from the chat room.
Any other question before we end the session? So I guess there is no more question. Thank you for your time and attention. So I think we come to the end of the session. And should you have any information that you need from us regarding our test, maybe troponin or other than troponin, feel free to contact us, and then we provide more information. Okay, so with that, again, thank you. Assalamualaikum warahmatullahi wabarakatuh.